Good morning, everyone. This is Raj Dave from Camp Hill, Pennsylvania. This is Coffee Cases and Controversies session for C3. And it's a great privilege and honor to have a very distinguished guest and the panelists joining me today for this outstanding discussion. It's an honor and privilege to have Masahisa Yamane sensei from Japan today. He is a senior attending physician at Saitama Seki Shinkai Hospital, and he's a widely known leading specialist in CTO PCI. He's been a great contributor and supporter of C3 Congress for over 15 years, and it's very well known in CTO intervention. Also like to welcome Dr. Ashish Pershad from Chandler Regional Medical Center in Arizona, and is also a well-known interventionalist and expert in a complex CTO intervention. And he's going to be sharing some new devices and pearls for CTO angioplasty. And it's a great privilege to have Dr. Javier Escaned from Hospitals Clínico San Carlos from Madrid, Spain, who he's head of interventional cardiology and has been a frequent visitor of Coffee Cases and Controversies session, as well as on Scientific Advisory Board of C3 Congress. He is going to talk today about CoreFlow device and how to manage patients with chest pain with no angiographic coronary artery disease. So we have a very, very full schedule. And without further ado, I'd like to turn over to Dr. Yamane to show us the first case. I also want to welcome our panel members, Dr. Parag Doshi from Chicago, Dr. Goran Olivekrona from Sweden, who recently had a health issue. And despite that, he's been very, very kind to give his time in recovery. So I want to wish him well, and our best wishes are always with him, and we're always there for him. And also Dr. Dimitrios Nikas from Greece, also a well-known CTO interventionalist as well as peripheral interventionalist. He's actually attending a peripheral vascular congress in Greece, and he's taken a time off of that to be part of this session. So we'll keep going, and my job will be today to moderate all of the cases, and there are multiple questions that will come from audience. I will also pass on those questions to our panelists. I don't want to forget Dr. Amir Kaki, who is a director of interventional cardiology in Detroit, and a great interventionalist, and is very, very involved in not only CTO PCI, but hemodynamic support, and also an expert in CoreFlow device. So he will be helping us as well. And he's also taken a time out of his very busy schedule to be with us this morning. So Dr. Yamane, the floor is all yours. And if you want to share your screen, please go ahead.
Thank you very much, Raji. Always a pleasure and a great honor to share the experience of all of you. And here's my presentation. This is the case of the very long proximal RCA CTO. As you can see, always we start with the 4 characteristics of the CTO. That is a proximal cap and lesion length, as well as the distal landing zone and the presence of the collaterals or not. In this case, unfortunately, this is a mid-60s gentleman who presented with an increased angina and CTO characteristics defined by the JCTO score of 4. So we started with the integrate approach with the 7 French M+ type catheter because the proximal cap was very blunt, and started with the Guyonx 2 to 3. But we did have encountered very strong resistance where we started with the retrograde approach. This is, of course, a pro micro catheter. As we can see that we usually start with the visualization first, which describes the CC1 collaterals here to the connection to the distal PDA. And in this case, we did have some difficult time with the SUO03. So instead, we use the Sion black wire here. So after reaching to the distal part of the CTO, we confirmed that the distal cap morphology, which was unfortunately also blunt, so we facing with some calcified occlusion, bending proximal portion, as well as a long CTO. So as always, US colleagues encourage me to use a knuckle wire to cross any type of the CTO, which I follow the advice in this case. So antegrade and retrograde wire seems to be an overlapping in the middle segment, but aerial projection, which is very much important to confirm, both wires are overlapping. That means close proximity or distant, that is separate. So in this case, I blindly tried to advance a 2.0 millimeter balloon, and balloon inflation just conducted, which seems to be very close with the distal retrograde wire here. But on the aerial projection shows a little bit distance. So as a result, however, we may try with a little bit more deeper, a little bit more proximal. We cannot create any connection. So in this case, this is a small trick, but as you can see that we advance a second wire over the dual lumen catheter. This is the Sasuke here, and just using a stiff coated wire such as a double core wire such as a Gaia-Nex 3 in this case. And the idea is when you use antegrade second wire, probably you can navigate more precisely over the portion of the retrograde gear, in this case, which was confirmed by this middle portion and distal portion. As you can see, the aerial projection also showing the overlapping in the same level of the middle segment. So that means that if we open the balloon in this overlapping portion, probably we can make a small space in the geographical close antegrade and retrograde wires. And in this case, 2.0 millimeter balloon inflation. And after pulling back the retrograde wire, we advance the guide liner extension here to have a reverse cart, and the retrograde wire, which is a Gaia-Nex 2, actually went into the antegrade guide extension. So that is then a little bit easier for the retrograde wire externalization. And after that, antegrade balloon inflation and stent delivery, we can reach a very nice outcome. Although we can see a little bit dissection here, but the original idea of the retrograde knuckle. So compared with the other product of the dual lumen catheter, this Asahi dual lumen catheter have a little bit shorter tip. That means a more supportive as well as a deeper inside of a heavy calcified CTO segment. At the same time, this is a typical example of the two core wires which support the more push and deeper into the very hard portion compared with the other competitors. And the other competitor N has a double guide wire here, but it's not so much long to the tip. So my presentation is short, but the take-home message is retrograde dissection reentry is not visible in the always a long calcified tortuous CTO. Knuckle wire is, however, very much encouraging in crossing the any CTO in an efficient manner. Bilateral knuckle wire is, however, just a little bit unpredictable to the course of the guide wire. So sometimes which may be a risk of vessel perforation if we resort to the very bigger size of the balloon when it comes to the reverse cart. Wire coverage is pretty much important. Converge is a key word, not diverge. Converge is getting closer each other. So in that sense, the first antegrade wire, leave it there with the similar to the parallel wire technique, and using a dual lumen catheter, you can more controllable to place the second guide wire to nearby of the retrograde wire. That way you can use a double wire on the dual lumen catheter, and guide extension can modify the complex CTO the procedures to a little bit more affordable one. That is my message. Thank you very much for attention.
Thanks, Dr. Yamane. Let me ask Parag. Yep. Parag, you are a big fan of the knuckle wire technique. and I know Ashish will have something to say about this as well, but, in your community practice, what do you think about these dual knuckle wires? And given that we both are endovascular interventionalists, this is not a foreign concept to us. How frequently do you use this concept, and how frequently does it work?
So, Raj, thanks for the invitation. I mean, obviously, Dr. Yamane is a world expert, and you have wonderful operators, including Ashish and Amir and Goran. But I actually tend to knuckle fairly frequently. If I have calcified vessels, I'm actually somewhat more afraid of taking stiff wires and trying to direct them, because I feel that I don't have control and they can perforate easily, as opposed to a knuckle, because adventitia is fairly expandable. I mean, you can expand sometimes adventitia quite a bit, lot more than what you would think is the actual wire. So my approach would have been probably, since I'm not as good, I'm not extremely good with this, the Gaia 2 and 3 techniques of modifying. I would have gone with a double knuckle and larger balloon. So it's extremely frequent to summarize. What do you think, Ashish?
No, I think I just have a question for Yamane Sensei. So,
Yep.
In the past, I completely agree with the idea, but the use of the DLC, the dual lumen, is sort of new to me. Most instances, the small balloon sounds like a good starting point, and then having seen you at previous conferences and having had other operators discuss it, I know that, for example, Sumisuji Sensei and other people would bring in your IVUS catheter next, and then look and evaluate and assess where you are, and then decide the next step. Are you using the DLC as a step before bringing in the IVUS, or are you using it just by angiographic appearance of the two wires looking further apart than you're expecting to see?
Yeah, thank you very much, Ashish. You have the really core point, because since I just practicing many other places outside Japan, and where the IVUS is not so much frequently physically able to use. So in that sense, we have to coin something new. As you said, that since we know that the subintimal modification is pretty much important for the antegrade and retrograde ambiguity. So I try to think something new for the so-called external crush technique. So if we use some knuckle wire, which may be a little bit awkward to use a larger balloon for just a calcified portion in the bigger vessel. But if you use a DLC, probably first knuckle wire obtains some safety remaining inside of the vessel. And second wire is actually directive to getting closer to the retrograde wire. So in a sort of application of a subintimal modification, besides the second wire usually is crossing some subintimal space to some true lumen. I don't know, because most of the cases, it's very hard to advance the IVUS catheter situation. So IVUS is not be advanceable most of the time. But even in that case, that some modification of the second guide wire navigate microcatheter crossable and then small balloon dilatable. So as just the external clutch, we can usually use a very big balloon inside of the CTO, which will result in a very nice retrograde and antegrade dissection reentry. That's my
Dr. Escaned, do you have a comment?
Yeah, hello, Masahisa. This is Javier speaking.
Javier, yes, very nice meeting you.
And I like very much, of course, the case. And I think that this aspect of looking convergence of wires, when you see that they are, at a big difference, is really important. I have two questions regarding this. The first is, I guess that it's probably good to start this strategy as soon as you see that your wires are very far apart, instead of trying to move much around and generating a larger dissection. I think that probably that's one of the aspects. And the second question is, in cases like this where you have extensive calcification, will you try to perform convergence with the new wire at a location where you see less calcification, or what would be your strategy? Because I guess that extensive calcification may be an obstacle for the second wire.
Yeah, I think since you are working with me more than 10 years, you have my point too. So that the first question is probably since we know that the some kind of a radio opacity alongside of the vessel, probably we can just navigate a very stiff wire alongside of the first guide wire. But so far, I have tried almost 5 cases because of the Dr. Dimitri, New York, he exhibited those kind of a subintimal modification at the time of the AHO, first time several years ago, and he ballooned it over 3 millimeter with a second guide wire, which worked very well. So I think as long as we can navigate the second wire inside of the vessel, which is very easier even with the Confianza Pro. Sometimes Confianza Pro inside of the calcium tends to be a little bit knuckle. That means we are staying in the vessel architecture. So that says we can just keep alongside of the vessel architecture. So it's a little bit different sensation with just pushing the knuckle, but still we are half directive, half application of the knuckle, those kind of things.
Well, thank you very much, Dr. Yamane, for this wonderful case and lots of learning. Let's continue with the program, and now I'd like to have Ashish Pershad to show his CTO case, and then we will have a chance to have a discussion.
Can you guys see the screen?
Yes, we can.
Oh, wonderful. So once again, thanks, Raj. Thanks, everybody. It's so nice to see Javier and Sensei Yamane, and of course, Parag, who's getting thinner every day and looking amazing. And great to see everybody. So again, in a short time, I'll go over, I have 4 cases, but not long, just quick cases to illustrate some good points about dual lumen catheters. Obviously, no real disclosures except being compensated by Asahi for my time related to this presentation. So if you look at the evolution of dual lumen catheters, if you look at them under 4 different categories: profile, use retrograde, ease of visualization of the over-the-wire port, and ease of withdrawal over trapped gear. Those are the 4 points that I like to emphasize. Of course, the export was our poor man's dual lumen catheter when we didn't have other things. It has a large profile, very poor visualization, and you very rarely could trap it, and a lot of the times you'd end up losing the wire. Moving to the twin pass, which was the next generation, I think the profile is intermediate. You can't use it retrograde. The visualization of the over-the-wire port is borderline, and oftentimes the wires intertwine, and it just is not a great catheter when it comes to withdrawing gear over trapped equipment. Then you talk to the new kids on the block, Enhancer and Sasuke. I think Enhancer I don't have experience with, but I'm sure I've talked to some of my folks across the pond. I'm sure Javier knows people who use this. I'm sure he's got experience with it. Maybe Sensei Yamane has too. But in my experience, what I've been told is that it has a small profile, has potential for retrograde use, has good visualization of the over-the-wire port, and has reasonable withdrawal capability over trapped wires. My experience has largely been with a low-profile Sasuke available to me for the last couple of years, or a year and a half now. It's extremely, extremely versatile catheter and provides me several advantages. Being small in profile allows it to retrograde, great visualization of the over-the-wire port, and very easy withdrawal. So those are the 4 points that I wanted to make related to catheters. And so this is a case where, similar to the first case, previously stented, heavily calcified. Unfortunately, the stent was into that high branching PDA. So we were able to get a microcatheter and a Gaia next into the posterolateral branch with relative ease, as can be seen here. But then you have a stented segment into the PDA, and what do you do with a circumstance like that when you have a distal cap at the bifurcation and you're trying to figure out how to rescue this, or if at all it needs to be rescued? So here's where I think the utility of the dual lumen coming comes in handy. You bring in the Sasuke right up to the bifurcation, and in real time, you can see in the left panel, just past the bifurcation, you know exactly where the port is. You bring it back, and a Xi'an Black can negotiate the PDA and can take care of this. And obviously, the idea being you want to have both distal vessels preserved so that you can preserve the long-term durability of an outcome in a CTO. And this is the final outcome where you now realize that you have a big, high arising PDA that was inadvertently previously stented. And then you have this PL branch, which is also big. And image on the left is the pre-image, on the right is the final angiogram. So big vessel, nice outcome, dual lumen catheter to the rescue. This is a second case, again, similar right coronary, this time demonstrating the utility of a dual lumen catheter in the proximal cap. This is a 66-year-old female. The cap is non-ambiguous. You have a side branch in the RB marginal. Again, decent distal target and pretty much mildly calcified. Not too complicated. But the advantage here is you can bring in the dual lumen catheter into the proximal cap. And at this point, you have you wire the marginal, you bring in the Sasuke. Once you have the Sasuke there, another great combination of the two, I think, is a Gaia Next and Sasuke, because of the tremendous tip control you have with the next family of wires, especially in a non-ambiguous cap. And you can see that you're able to negotiate the CTO body comfortably with the microcatheter. The Gaia is still in the distal vessel. Once you've done this, you can then give up your RB marginal wire, get to work, and have a great result with stenting of the vessel and great preservation of both branches. This is a more complicated case. This was a patient with a low ejection fraction post-cabbage, previous ICD. You can see his only patent vessel was the Lima. His LV function is poor. And when we looked at this, the viability on the MRI showed that the entire inferior wall was viable, yet there was very poor visualization of both the PDA and PL branches from any vessel, except that faint filling of the PDA that you see filling from the distal LED and the septals. So obviously, didn't want to go retrograde in this circumstance where the patient had a low EF and using the only patent channel, which was the Lima. So we decided that we were going to try to do this in an antegrade fashion in the best way we could. And so we sort of got going and decided to mini star the PDA and try to see what we got. And you can see that we have a knuckled wire and we have a vessel that has flow into just the distal vessel. It's a single vessel and it's a PDA. We couldn't see the PL at all. Once we opened the PDA, you can see some really faint filling of what looks like a posterolateral branch. Based on his MRI and the viability, I knew that there had to be a PL that was just not visible to us. So what I did was I brought in a dual lumen catheter once again to where I thought I saw a silhouette of the posterolateral branch. And this time with a combination of the Gaia Next 2 and the Sasuke was able to wire the PL. And you can see that once you wire the PL, boom, you have a whole new vessel. You have a vessel that you could not even angiographically see or even assess via collaterals. And you now have a much more durable result with two vessel outflow, bunch of septals, branching PL, as opposed to just a dinky PDA, which would have been sort of the outcome that I would have accepted in the past, but would probably have not been in the best interest of the patient long term. So that was another great example. And then the last case is a more complex case I did recently, a long CTO, heavily calcified, previously failed antegrade cap. We did base proximally with a 3.5 millimeter NC balloon to start an antegrade knuckle because obviously we didn't want to traverse 100 millimeters of the CTO trying to wire this, having already failed twice. So we were able to create an antegrade dissection with BASE, which is what BASE stands for, balloon-assisted subintimal entry. And once we did that, we were able to traverse the 100 millimeter CTO with a Mongo and a knuckle and set up for ADR with a Stingray just proximal to the bifurcation, as you can see in the right panel. Once we had the ADR set up, we got into the posterolateral branch in ADR without too much difficulty. But flow in the PDA was compromised. And even though we were proximal to the bifurcation because of the several attempts that we had with the Estado trying to re-enter the PL. So what we did then was we brought in the Sasuke once again into the distal cap this time, and was able to use the versatility of the Sasuke to wire the PDA, knowing that we were in the true lumen proximal to the bifurcation, because we had device-based reentry that was pretty precise, proximal to the distal cap. And as you can see in the lower panel on the right side, we've now got access into both vessels and could again get a durable result by handling the distal cap, and both branches were preserved. And then going back into final conclusions, I would say, dual lumen catheters have become a very, very useful tool for complex cases and in general CTO PCI. I've shown you case examples of both the utility of the dual lumen catheter for both proximal and distal cap situations you run into. The other point I wanted to make was that not all dual lumen catheters are the same, and you need to have some familiarity with both catheter design, as Sensei Yamane showed us, as well as the distance of the port of the second lumen, so that you know when you're using a twin pass torque or using a twin pass, or whether you're using the Sasuke, you have a good handle on where the over the wire port is. And then of course, I urge caution in managing both the over the wire port as well as the balloon and the RX port. And oftentimes in trying to back these catheters out, you don't want to inadvertently lose wire position, because then you're starting all over. Thanks for your time, and hopefully I didn't run over. Those were my pearls on using the DLCs and some nice case examples.
Thanks, Ashish. Let's ask Amir. Amir, this catheter appears to be a very useful catheter for even bifurcation. Because if you have a lost side branch or something, it can be extremely useful. And I think that, I talked about this at the American Bifurcation Club meeting recently, and it has multiple uses, including the CTO. Javier, you had access to Sasuke catheter for some time now, right? In Spain.
Yeah, absolutely. I find it very useful. I think one of the characteristics of differential characteristics of Sasuke is that first, it is a long double lumen microcatheter, so you can use it also retrograde. The second one is that you can orient it. You can twist it slightly, which sometimes is useful actually. I mean, so if you can twist it, sometimes you can get proper alignment between the sides hole and your aim, either if it's a side branch or if it is a particular location in a CTO. And it's very lubricious. It's extremely, extremely lubricious. So I think that it's probably one of the, from my perspective, one of the state-of-the-art microcatheters with double lumen.
Yeah, Yamane Sensei, you met Ashish mentioned a catheter called Enhancer. I don't think that's available in US anyway, but you may have other dual lumen catheters in Japan besides the Sasuke. Are there other catheters that you use?
Other catheter is a Crusade, for example. That is a fine dual sold in the Europe, but a little bit weaker. But I'd like to mention one characteristic of the Sasuke, as Ashish mentioned. Actually, the easier to the second guide wire maneuver means that the more support, and some of the benchmark studies show that it's more penetrable and more supportive for guide wire control than the Corsair Pro. You may not believe it, but once you have a first guide wire and Sasuke, second wire penetration is more forceful than the Corsair Pro alone, or that any other microcatheter, because the tip is so low profile, like Carragher microcatheter, the same, but the shaft is supported by two guide wires I explained. That's why you stabilize guide wire deflection control more precisely as you wish to go. That's the kind of things.
That's a great point. That after you have the first wire, you can put Sasuke over that wire, and the second, pushability of the second wire is phenomenal. Ashish, you seem to really like it, this catheter, and have done multiple cases with it and have a lot of different uses. Have you had to use it in other indications besides the CTO, such as bifurcation or things like that?
Absolutely. Like you said, Raj, I mean, it's very valuable in bifurcations, especially narrow angle bifurcations like diag-OM bifurcation that is extremely, if there's a risk of loss of side branch and inadvertent loss of side branch during treatment of a bifurcation, I think this catheter comes tremendously handy. And I think I can't, CTO PCI is one thing, but I think for non-CTO operators, this catheter will come of great use in multiple scenarios. And as Yamane Sensei said, that I think the tip control and the lack of interaction between the wires, I think, differentiates this catheter in the sense that when you use, I showed examples of Guyanex, but even if you use like a jacketed wire, like a Xion Black as a second wire, or if you use something other than, and in a non-CTO case, there's very little interaction and the control of the tip is exquisite.
Goran, what do you think about the trapping of these catheters? Have you had experience with that?
I mean, this is one of the interesting things that which is great with both the Suzuki and the enhancer, that if you use a 6 French system and you use it for bifurcation or something like that, you can both easily trap them out, as opposed to try trapping twin pass or fine duo. You need the 7 French catheter for that. And I agree with all the previous, what has been said about the advantage of using dual lumen catheters. It's multiple uses. One, I think, which is a sort of standard type of uses when you do a DK crush and you have difficulty with recrossing after the first stent. And if you want to be really certain that you can bring a second wire in along the first wire, you can always use a dual lumen catheter if you sort of had difficulties with rewiring. And I think, be certain that you are in the right location before you do your recross. That's sort of a go-to option after doing that type of procedure.
Yeah.
Because
so these are all, yeah. Go ahead.
Sorry, it guarantees you not going behind the stent strut, even if you do pot, as Yoran was saying. I think if you have the protection of the wire over the microcatheter, then you're not going to get behind the stent strut, and that's really important.
Exactly, Ashish. That's sort of the point. I mean, you don't bring it out, straight away, but if you have difficulty, that's sort of a go-to option that you can use.
If I may make just a small trick here. I mean, we love these double lumen catheters, and as we use them over and over again, we love them more and more. One thing I can usually do is when I have a really big bifurcation, I mean, dual lumen microcatheter can help you easily to identify the mid or the distal reentry. So we put the microcatheter in the main branch. We have the marker of the other jail branch. You do a nice stent boost, and then you see nicely even the strut, but you can enter. You can actually target the main strut you can enter. So whether you have a DK crush or just a wire, you do mid or distal reentry. That's really something helps a lot, and you cannot make this happen without the dual lumen microcatheter. So this is an important thing, especially in bifurcations.
Fantastic. Thank you very much. So today was a day of unmet needs, and double lumen catheter clearly was a big unmet need in US, and now with the availability of the Suzuki, it really fills it. Now let's turn to the second unmet need, and it's an honor to have Javier Escaned from Spain to talk about that, and that's how do we deal with patients, those who don't have angiographically severe coronary disease and still complaints of chest pain and frequently come to the emergency room and the cath lab, and really, this is a weekly affair at least in our lab, and it's very, very difficult to determine what therapy to do for these patients and identify truly the etiology, whether they have microvascular dysfunction, whether they have coronary spasm. So Dr. Escaned has a tremendous experience for years dealing with the physiology and microvascular dysfunction. I'll turn it over to him now to show us the next case. Javier, you may be on mute.
Oh, thank you, Raj. I was just saying that it's a great pleasure to be, at Coffee Cases and Controversies. I make sure that I have brought my coffee with me. And I'm really enjoying this meeting with friends, and I'm sure that the colleagues online are also enjoying this. And as you mentioned, the topic of my presentation, the cases I'm going to present have to do with exploring what happens not only in the epicardial vessels that are accessible with coronary angiography and with IBUS, etc., but more importantly with the very extensive network of vessels that we have in the microcirculation and that have enormous importance, of course, for the function of this complex system. The starting slide is, remember that when all of us were at the medical school, we were taught about the importance of the coronary microcirculation, but I'm sure that, like in my case, you probably never saw a case with a diagnosis of microvascular dysfunction in your clinical practice. Fortunately, this is changing. So let's change to one example. Please, Amir, Ashish, Goran, be ready because I'm going to ask you what will you do in this particular case, okay? So this is a case that to me was an eye-opener. It happened a few years ago. This patient had a stent in the circumflex, but continues having angina. So he comes back to the cath lab. There was actually a positive exercise tolerant test. One of my colleagues makes this angiogram, and well, he sees nothing over there. But looking carefully, he decides to check that proximal LAD stenosis. And as you can see, he made an FFR and found that it was non-significant. So this is very easy. And I think that many of us will be doing this, okay? Now, the problem is that the patient comes 9 months later, and he, this is in the context of a preoperative non-cardiac intervention evaluation, and he has ischemia in a non-invasive test, and he says that he continues having the same angina, since the time he had angioplasty. So I'm going to show you the angiogram, and then I will ask, let me see if it works. Let me see it again. Yeah. And then I probably will ask Goran. So Goran, be ready and you tell us what would you do. This is the angiogram as it looked like it was before. Exactly the same. I'm going to try to stop here. And then you tell us, what would you do at this stage? Will you say, as my friend Bruce Hamel says, growing closure and going for lunch, or will you do something else?
Thank you, Javier. No, I mean, I think this is what you taught us, that, angiographically and perhaps with IFR, FFR type of measuring, it's not the whole answer. So I would say that we need to do testing of myocardial resistance and CFR.
So, we are good friends and we are fully aligned. I was doing this case. So I say, oh, I'm going to be more clever than my previous colleague, so I'm going to put thermodilution pressure wire, and then I check. And then what I found, let me just make an interpretation for you, is that, sorry about that. Let me just go back if possible. Yeah, I will try to scroll it up to this point. Yeah. So what you are seeing here is that fractional flow reserve, FFR, was, again, non-ischemic. Coronary flow reserve was 4.4. That is very good news. That is really good news. I mean, you can imagine, 4.4, it's, let me just, sorry about that. Oh, okay, well, it was 4.4 and resistances were entirely normal. So I reassured the patient, that he had no problem in the microcirculation, and I told his physicians. The problem is that the patient comes back 3 months later, and he has effort angina during, he actually has a chest infection, and now he has effort angina previously, but now he has, during admission, coincided with fever, he has ST changes with the ST depression. So my colleagues are knocking at my door and saying, Javier, please, can you please put a stent in that LAD and forget about, let's forget about the whole thing. So Ashish, what would you do at this point? Will you follow the advice of your colleagues, or you can see that I proceeded to an angiogram, but I'm not going to show you what we found. What would you do?
No, I think that number one, before we get to that, I just needed to say, what medication treatment was he on during this whole intervening phase between his initial presentation? I know that chest pain syndromes with angina are common, and I also know that their outcomes are worse, but what was he treated with?
So the patient basically had a good treatment in terms of secondary prevention. And I believe that he was on a beta blocker for hypertension. That's basically what I will say at this point, which, you know, was deemed that will be a very good solution also for chest pain, despite that, you know, there were no obstructions and there was completely normal microcirculation according to FFR and CFR.
Right. No, I mean, I think the next step is, I mean, I know that the outcomes are worse. I think taking him back is a good idea. The next question is acetylcholine provocation.
That's very good. Absolutely. So this is what I found. Of course, I could not rule out that there will be restenosis, but you can see the stent looks great. Actually, it looks much better because of the rest of the arteries, partially because I decided not to give nitrates to start with. Now, I don't know how many of you had acetylcholine testing. At that particular point, I did not have acetylcholine testing yet. This was something like 6 years ago. So I asked the patient, told him, when do you have chest pain, sir? And he told me every time that, you know, I climb a flight of stairs or something. Okay. So then I say, well, I do not have acetylcholine testing, but we have exercise. So I asked the nurse to provide a couple of bags of saline to the patient, and we decided to do some exercise. Actually, that's the reason because I did the case using the femoral root, you know. So the patient started to exercise in the cath lab, you know, and then we had a look to what happens in the angiogram and, of course, in the EKG. And at the beginning, everything looks quite all right. You can see the EKG, you know, is normal, no changes in the angiogram. But as the patient continued doing exercise, he reported he had chest pain. I'm feeling exactly the same pain than I typically have. And this is how the angiogram looked like. So you can see that actually the stent looks better and better, you know, but the rest of the coronary arteries look dreadful. You can see that there is diffuse spasm and, of course, a lot of ischemia in the EKG. Okay, so what I did is I gave some nitroglycerin to the patient, and this is how the EKG looks like and how the stent looks like. Okay, so this is how we do it nowadays. We no longer use bags of saline. So we use it with a cycloergometer, you know, and we use Doppler and pressure. We prefer, of course, Doppler in this situation because we can measure this, and we do it in a specific patient. We can speak later about this, but certainly to me it was an eye opener, as I was saying before. But let me share some of the cases I learned from this. Some of the points I learned from this case. The first is that probably this guy never ever required a stent in the circumflex. You know? It was performed without performing FFR. It was just eyeballed, you know, and the idea that there was a need for placing a stent there. The second is that the patient was stuck in a loop of never-ending tests. He had already undergo these angiograms. There was one extra one I did not show you. He had multiple tests, etc. And this is a typical story of these patients. The clinicians encouraged me to perform PCI. This is very interesting. It was me, an interventional cardiologist, who was saying, wait. There was coexistence of ischemia of non-obstructive origin with functionally non-significant stenosis. That means that the patient was exposed to the risk of atherosclerosis in terms of, you know, having acute coronary events in the future, but also of ischemia of non-obstructive origin. And something very important, a pressure guide wire with, you know, that allowed me to measure CFR or IMR, adenosine, could not identify what was the cause of the problem in this patient. So, you know, that's the reason, because subsequently I was the coordinator of this particular section of the ESC guidelines on chronic coronary syndromes. And, you know, and we managed to reach a consensus that actually there was enough evidence to recommend the use of pressure guide wires to measure, with sensors to measure CFR and resistance, and that this should be considered in patients, you know, who have either normal coronary arteries or arteries that have normal IFR or FFR or any other index, like this case. And the second one, this is addressing, of course, what we call the structural remodeling endotype. And the second agreement is that, you know, you should consider also the use of intracoronary acetylcholine and EKG monitoring, because it has been demonstrated that this is very safe. And of course, in terms of non-invasive tests, remember that providing only information about the structural remodeling, not about vasomotor disorders, the use of non-invasive tests like transthoracic Doppler, CMR, or PET. And just to remind you, if you document the structural remodeling, of course, there are treatments that you can use. What you should do in that particular case, because you cannot change the structure of the microcirculation, is at least to reduce oxygen consumption with beta blockers, you know, as a first option. In this particular case, who had a vasomotor disorder, of course, the drug of choice is a calcium channel blocker and nitrates to start with, and of course, to add an ACE inhibitor and statins. And you have also other situations, like, for example, the pain caused by excessive proprioceptive origin or whatever. In all cases, you have to introduce life modification and quantification of progress, if possible, with, you know, patient-reported outcomes like the Seattle Angina Questionnaire. So I will very quickly show you any other cases, but perhaps at this point, if you want to discuss something about this particular case, we can take 1 minute. Raj?
Yes, so there was a question from the audience. Dr. Maren Wefferling would like to have a scheme for acetylcholine testing for the cath lab, and she congratulates you on this phenomenal case.
Fantastic. Well, so absolutely. So we will explain this in a second, but let me just anticipate that it is very simple. The protocols that we use nowadays are simplified protocols. That means that you can give them directly through the guiding catheter. No need to go selectively into a particular vessel. We typically do it in the left coronary artery because, you know, it provides 75% of the blood to the myocardium, so you can check if there's anything there. Only occasionally we go to the right coronary artery. And what we do is we prepare a stock solution with acetylcholine. We have a special color drip to the table, so we know that we are working with acetylcholine. And then we make dilutions, you know, of 2 micrograms, 20 micrograms, 100 and 200. And we give each of these hand injection over 40 seconds, 30 seconds. Very safe and very simple. So let me just continue then and show you some other examples of this problem. And let me first, for example, show you this situation, that this case with patients that have epicardial coronary artery disease. So this is a patient that is a patient from the Indian subcontinent. He has 50 years old. He's 50 years. He has hypertension, dyslipidemia. He has diabetes mellitus, family history of coronary artery disease, and he has effort angina with an exercise tolerant test that triggers angina but no EKG changes. And in the angiogram, he has this stenosis that you have there. I can anticipate to you, and you will see it in a second, that we did a pressure guide wire, and these stenosis were non-significant. So I really look forward to your comments. I guess that because we are talking about non-obstructive coronary artery disease, we can focus on what were the findings. But you can see is that first, FFR was non-ischemic, 0.85. But here you can see the course of thermodilution, you know, performed at rest and hyperemia. You have the time in seconds that takes to recover temperature, 0.61 seconds at rest, a bit less, of course, 0.35 during hyperemia. But that makes, you know, a coronary flow reserve of 1.7, which is abnormal, it's less than 2, and a resistance of 28 units. You have to use corrected IMR, which adjusted to FFR. Okay. But this is what happened also when we gave the patient acetylcholine testing, and now we are using acetylcholine over the last 4 years. So, and what you can see is that, well, there might be a small change in vessel diameter, but certainly there is no epicardial spasm. But you can see the huge changes that you can see in terms of ischemia and also chest pain. So the patient has certainly microvascular spasm. So in this case, you know, you are talking of a very sort of complex and perhaps, you know, the end tail of the spectrum of coronary artery disease. Someone who has coronary atherosclerosis with, you know, nearly obstructive lesions, functionally not obstructive because he has also changes in the structure of the microcirculation and also vasomotor disorders. So we thought that the dominant aspect was the vasomotor problem. So we gave calcium channel blockers. It would be possible to consider, you know, alternative treatments, but we started with these statins and ACE inhibitors, and of course, to focus very much on the anti-diabetics and aspirin, obviously, because this patient has epicardial coronary artery disease. And we started a diet and lifestyle recommendation. In patients who have prior coronary interventions, I will show you this and then I will stop. Very important to remember, if we look to the ischemia trial, it's true that invasive strategy is much better than conservative, you know, in terms of controlling angina. But for example, for a Seattle angina questionnaire, angina frequency score of 50, for example, that means that 1 year in the invasive arm, 40% of the patients continue having this amount of angina. So you can see that actually actually PCI is not an optimal treatment to treat anginas. This is a conclusion we can reach. So let me show you these patients. This is someone in a way resembles the first one, lady who had hypertension, dyslipidemia, and had a tight Medina 111 stenosis at this bifurcation. The interventional cardiologist did a superb job. He performed 2 stent technique, and as you can see, in the long term, looks great. The problem is that the patient was never relieved from angina. So what we did in this patient is, and I'm going to show you first the acetylcholine testing, is we injected the acetylcholine testing, and you're going to see basically how we do it. You know, it's a hand injection. We typically keep an eye also in the thermodilution, so we see how it goes. The first dose, causes no changes whatsoever in the angiogram. EKG looks okay, but the 100 microgram dose, you see this non-reflow phenomenon. Look at that. There is no epicardial spasm, but you can see that the blood is running like when you have no reflow, and you have EKG changes. This is microvascular spasm. This is the spasm that takes place at the arterioles, and of course disappears immediately when you give nitroglycerin. And we perform also in these patients coronary flow reserve and IMR. So this is something that I believe, Raj, that we forget frequently. After PCI, people who have continued having angina may have major disorders. This is another example of someone who is similar in this situation. And look what happens when you give acetylcholine testing in this particular patient. So I think it's a situation that actually happens quite frequently, and that we have to understand that perhaps in the future, we will have less of this if we test in advance people who are planned for interventions for microvascular dysfunction or vasomotor disorders, and therefore we start medical treatment before that. But for the time being, anytime that we have someone who has persistent angina after PCI, this is for us a key indication for these studies.
So that was fabulous. And I very, very strongly believe that this is such an unmet need worldwide, and especially in US. And now with the availability of the CoroFlow device, you know, it's very nice with having CoroFlow that you can see all your numbers right on the screen. You know, you have your FFR, CFR, IMR, and it's very easy with the Bluetooth wire that you are connected. and you can perform this testing. So, and that really, at least for patient education, I feel that it's very, very important that I can tell my patient what's wrong. Because a lot of the time, even though I may have suspected it, that, patient may have microvascular dysfunction or spasm or something, I don't have a definitive answer for the patient, why patient continues to have chest pain. I think that that's very, very helpful to me to be able to pinpoint the diagnosis and to be able to explain to the patient so that, I can exert a change in their medical therapy or their behavior, stop smoking, take cholesterol medicine. And the patient is much more, I just, I know we have spoken about this, a couple episodes ago. I want to just reiterate in the last few minutes. Tell us, how you do the thermodilution injection, because I think that there are some operators who have reached out to me and asked me that question a couple times now. So there appears to be some confusion. I know it's very, very easy, but tell our viewers, how you do those small syringe injections.
Yes, let me just, perhaps what I can do while I answer is just show you the
Video.
the case that, yes, that the case that we were just seeing. I think that it was, I had one additional case that I wanted to show you, but let me just show you this, because I think that we have in the video the sequence of what we do. So what you do is you make hand injections of saline boluses. This is, I'll show you in a second what I do. You can use a stopcock, or personally what I do is just take, injections with saline, connect them. Every time that you make an injection, a brisk injection, there is a drop in temperature that you can see here, and that translates into one of these curves. So you perform it's around 3 cc's of saline room injection at the beginning, at rest. Then you induce intravenous hyperemia. You induce myocardial hyperemia with intravenous adenosine or rigadenosone, if you wish, and then you perform another 3 injections. And as you can see here, the time of this recovery of temperature moved from 0.53 seconds to 0.27, and that translates into a coronary flow reserve of 1.9. And also, if you multiply the hyperemic time 0.27 by the distal aortic distal pressure, 78 millimeters of mercury, you will get this value of resistance, which is 21 units. Typically, we take as abnormal above 25. Very simple, and really something that any of you can learn. There are small tricks like, making brisk injections, replacing time to time these things. You really have to, for example, make sure that you have flushed the catheter before starting the 3-3 saline injections. But apart from these small tips and tricks, it's really easy to use.
Goran, do you have some questions for Javier?
No, I saw there were some questions and answers, and the first one for Javier, I think, that do you always perform FFR up front before testing on CFR-IMR, even if there's no obvious stenosis in the vessel?
Yeah, I mean, that's, well, of course, I mean, if you don't see stenosis in the vessel, it's quite unlikely that you will have, a positive FFR, unless there is something that you are missing. That's for sure. The good thing about FFR when you're performing this test is that it comes for free. And that's the reason, because, I mean, being one of the introducers of non-hyperemic indexes, I always insisted that I still kept using adenosine, because we were doing a lot of these measurements in our patients. Now, I can tell you that there is ongoing research. We're doing a study now trying to do this with intracoronary adenosine. And it looks like it is feasible. Although it is true that you really need a bit more of practice, so to make sure that you make your injection of adenosine and then you make very quickly the 3 saline injections. But the technique is being simplified. I believe that over the next couple of years we will see simpler versions of the protocol for performing these measurements.
So, Professor,
good question.
Yeah, Ashish.
Sorry, just going to ask you one, Dr. Escaned, the case that you showed, I think we've all seen patients like that where we have a challenge in making the diagnosis and they come repeatedly to the cath lab. What's your threshold for initiating the exercise test in the cath lab? Is it after they come once or twice, or do you do it if their CMR is negative?
You know, the exercise testing is really, really interesting. And let me just share with you an additional, if I may, let me see. I think that you are seeing this. Let me just show you an example that is revealing of the potential of exercise testing. This is a patient who had 56 years hypertension, left ventricular hypertrophy, and you know, the patient exercised, developed chest pain, at the same time left bundle branch block, something that indicates that there is something very wrong, okay? So we wanted to understand really what happened in this patient. You can see here the Doppler wire. Obviously, exercise, you need to have continuous monitoring of what is going on there, or at least is what we do. But perhaps it will be possible to do something with thermodilution. And see what happens with this patient, because I think that you're really going to enjoy this. So the patient has normal EKG at baseline and then starts exercise. And look at the flow velocity at the beginning. At the beginning, this lady had about 40 centimeters per second of blood flow velocity, the lady. When she's at the stage 2 of the Bruce protocol, there is no increase whatsoever in flow velocity. It's still 40 centimeters per second. At the stage 3, it's 44 centimeters per second. So it is so dramatic to see that despite that this lady is exercising, she's unable to increase blood flow in the lady. And suddenly she develops left bundle branch block and angina. Exactly the same thing that was happening, you know, in the exercise tolerance test. It was amazing. And now you understand why she is developing this left bundle branch block, you know. So she's so compromised for the effect of left ventricular hypertrophy, perhaps on coronary microcirculation, that she must have a lot of remodeling of the microcirculation. So the only thing you can do in these patients, you know, for the time being, is help the patient by reducing oxygen consumption, give an ACE inhibitor and statins, you know, to reduce potential inflammation, but also to help the endothelium, and be very strict with hypertension. And with that, we hope that we can control the symptoms. We don't know if we will be able to change the prognosis, because we don't have studies that have demonstrated this so far, but at least we can help the patient in this regard, and we understand much better what is going on. So this is one of the examples, Amir, where you know, we opted for going for exercise testing. We will have missed this very rich information if we will be doing the conventional type of studies.
What percentage of your patients? No, I just wondered what percentage of your patients, Professor, actually do you end up? It seems like it really is very enlightening, and it seems to unmask the diagnosis that we probably all of us often miss. So my question is, like, how often are you doing this? Is it 1 out of 10, or is it every patient that has a normal CMR?
So at our center, you know, there are over the last 5 years, there are 2 subgroups of patients that have rocketed. One is TAVI patients, and the other one is non-obstructive coronary artery disease. And the reason is because we've been very successful in involving our clinical cardiologists. So it is the clinical cardiologists who actually are requesting to us that we provide this type of information, which of course we do. We are delighted, you know, to do that for them. And they get information, and they perform a better tailored approach, which, as you know, was demonstrated in the Cormica trial that helps these patients. Regarding exercise physiology, we do it in a minority of patients. We select the patients that we want to do this, you know, because we are interested in there's a very strong relationship with exercise, with effort, angina, etc.
The last couple of questions from audience. Dr. Janusz Bogdan from Poland is asking, is this kind of testing, would you do in acute coronary syndrome?
Well, no, not really. In acute coronary syndrome, it may have a lot of value. And obviously, I strongly believe that, that the next stage in treating patients with STEMI will be, once that we have opened the vessels, understanding if these patients have, who of these patients have damage in the microcirculation, extensive damage that, will dictate a poor prognosis in the future. And then hopefully, by having this information, being able to incorporate any treatment that helps. But this is, for the time being, it's something that I'm sure it will sooner or later happen in one version or the other, but we don't have that. The other advantage in acute coronary syndrome sometimes is to identify which is the culprit stenosis. In situations where you don't know where you're assessing, then you find a vessel, where your IMR is very high, you have no coronary flow reserve, and then you understand that probably this is the culprit vessel of the acute coronary syndrome that you were not able to identify due to the fingerprint that is left in the coronary microcirculation. But this is, otherwise, we do not perform acetylcholine testing in the acute setting. We don't do that. We just, subsequently in Minoca patients, we perform acetylcholine testing, but never in the acute setting.
Yeah, thank you very much, Javier. This is a wonderful talk. Yeah,
it's great. So one last question, and then we'll conclude. My colleagues and I have sometimes problem with the quick saline injections for CFR IMR assessment, as the console shows error in amplitude. Do you have a tip for resolving that?
Yes, so I can give you a couple of tips and tricks. I mean, the first one is remember that actually the wire is sensing temperature at two locations. One is at the wire shaft, and the other one is at the thermistor that is located 3 centimeters from the distal tip. So, for example, if there is anything in the shaft that is, interfering, you will not have a problem. I give you a typical example. You decide to put a microcatheter. So if you put a microcatheter, you are putting a plastic sleeve on the shaft, and then, the system is telling you low amplitude. And it took us, a while to understand that this was the cause. So never perform a thermodilution using a microcatheter over the wire. Second thing is that typically is you should be properly engaged in the coronary artery, otherwise you will have. And the third one, very important, is that it has to be a brisk injection. Make sure that your guiding catheter is coaxial to the vessel. I mean, it's not typically, there's not much problem because you have a wire that is impeding to have the catheter pointing towards the ceiling of the left main or whatever. But make brisk injections. And this is much more important than longer injections or more volume of saline.
I think that those are all great points. We're just a little bit over time. I know Dr. Punjani from India has asked us a few more questions. I am going to reach out to him and answer those for him. Thank you very much, all the panel members. I know it's very late in Japan. We have audience from practically all over the world, including many people here from Asia, Indonesia, Malaysia, and Japan today. So thank you everybody for hanging in such a late evening for you all. Thank you, and have a great afternoon in Europe and a great day to all our attendees here in US. We look forward to having another one of these great sessions next month. Dr. Amir Kaki, who served as a panel member today, is going to present a phenomenal case of OCT. Next month, and there'll be several other very interesting things. So we look forward to having you all again next month. So have a wonderful weekend. Thanks for joining us, and thanks everyone for your valuable contribution.
Thank you.
Thank you very much, Raji. Have a great weekend.
Thank you, Raj.
Thank you
Bye,
very much.
everybody.
Thank you.
Thanks.
Bye, everybody.
Thank you.
Thank you.
Thank you very much. Yeah.